Now this is kind of interesting. If you look at the distribution of blood in the body, which figure 21.7 is showing us, right? What we'll notice here is about 65, maybe 70% of our blood at any time is actually in the venous system, right? And so that leaves, what, 35% of our blood to be in the heart, in the arterial system, in the capillaries. Okay, now think about why that is. Why is 2/3 of our blood in the venous system? It actually, the venous side has much more capitance or expandability. Remember in all our arteries, they had all those elastic fibers, they kept recoiling, right? The venous system isn't like that, and so these vessels can really kind of fill up more, expand more. In fact, if you look at this, about 1/3 of our venous blood, right, which is already 2/3 of the blood, but 1/3 of that is actually in places like the liver, the spleen, the bone marrow. This is the so-called venous reserve. And this is blood that, in the case of, say, like a big hemorrhaging event or something, this blood can actually get called back into action in the body, right? We use venoconstriction. Right? We actually constrict veins, which we said, you know, they don't have a huge tunica media, they don't have a lot of smooth muscle, but they have some, right? And they do this venoconstriction, and they can actually push this reserve of blood back out into circulation and help the body make it longer. So we've reached the part of the chapter where we're now moving more into the physiology of how blood actually flows. So some of this is going to look a little scary, but I'll try to walk you through it, and we certainly have time and we can talk about this in class as well. So what we're going to kind of talk about first is thinking about how the heart is able to push blood through all these vessels, get it to the capillaries and through the capillaries in a way that we can actually get nutrient exchange. So we need blood to flow, which sounds simple, but of course someone figured out the physics of this. And what they say is flow is proportional to the change in pressure over resistance. Let me say that again, not in a mathematical formula. So, well, whatever, we'll just write it out. Flow is proportional to the change in pressure over resistance, right? So F stands for flow. This little symbol means proportional. Flow is proportional to the delta is a change, so the delta P, the change in pressure over resistance. In English, in plain speak, right, what this means is that you have to have a big enough difference in pressure to overcome the resistance of the blood vessels. If something is making there be more resistance, something like atherosclerosis, hardening of the arteries, maybe vasoconstriction, the only way to overcome that resistance, whatever's fighting the blood flow, is to make a bigger change in pressure, which really, when it comes back to it, it means that the heart is going to have to work harder, right? We talked about maybe ventricular hypertrophy. The heart has to work harder to push that blood through the vessels, okay? So if you think about this change in pressure, right, we can actually see this, right? This is showing blood pressure in our different vessels. So starting out at the aorta, they're saying we should have about 100 what? 100 millimeters of mercury. This is just a measure of pressure, just like barometric pressure tells you if a storm is coming in. Don't worry too much about the units. Millimeters of mercury is just a unit for pressure, okay? So we start out at about 100 coming out in the aorta, so that's how hard the heart is pushing, right? And that blood is beginning to flow. but we'll see that that blood pressure drops. Every time those vessels start branching, we're going to end up moving through smaller and smaller vessels, and we're going to see lower and lower pressures, right? The capillaries at the beginning, you can see we're up like, what, I don't know, 40, so already less than half that pressure. By the time we're leaving the capillaries even, we've lost about 20. We come out at around 20, right? And then we've already mentioned the fact that the venous side of the cardiovascular system is very low pressure. So to kind of understand this, these other graphs might be helpful there. So this graph is showing our vessel diameter. Of course, we start at a very large vessel. Our capillaries, of course, are minute, right? Some of them are smaller than the diameter of a red blood cell. But look what happens in the cross-sectional area. So that aorta, our big elastic artery, is huge, but there's just one aorta, right? And so in cross-section, sure, it's an inch across, but when you add together all of those capillaries, even though they're tiny, we end up with much more area, right? And this is how we deliver oxygen, nutrients to the body, and remove waste and CO2. Okay? And then also we see then, as we move into smaller and smaller vessels, that's going to kill our velocity, our speed that blood is flowing. And then actually when we start getting back into bigger veins, we can pick up speed there a little, though we do not pick up pressure, right? Because there's not a second pump to start moving that. Okay, so this change in pressure is going to tell us if we can overcome the resistance, then we can actually get blood flow. And we want blood to flow. We want perfusion of our organs. Okay, so this resistance, let's look at what sort of components are involved in vascular resistance. So total peripheral resistance is really made up of three main things. Vascular resistance, blood viscosity, and turbulence. Okay, again, total peripheral resistance, we're looking at the resistance that the heart is working against to get blood to flow. So most of what we're going to look at here is actually in vascular resistance, but we'll come back and talk about these other two as well. So when we think about what allows blood to flow easily, there's a few factors about blood vessels that are kind of restricting or resisting that blood flow. So the first one is actually the length of the vessel, right? So what's resisting blood flow is just friction, the interaction of blood trying to flow through a vessel and then it's rubbing up against the sides. So it kind of makes sense that if you had a longer vessel, you'd have more friction, right? It's harder to move through. Just like if you had a snorkel, you can blow and pop water out of the top. If that snorkel was 3 times as tall, it becomes impossible to create enough pressure, right? And that's just the friction, the resistance of that blood flow. So what we see is basically if you double the length of a vessel, right, you cut the flow in half, right? You increase the resistance. If you double the length, you double the resistance. And it's just a linear relationship there. Twice as long, twice as much resistance. Now, the other thing, this doesn't come into play a whole lot because really once you're an adult, the length of your vessels is more or less established, right? So our body has learned to overcome the amount of resistance necessary in the adult body size. Vessel diameter is much more pliable, changeable. Okay, and before we think about exactly how this changes, I like this picture. Notice what they're showing here. They're really trying to show you the friction. So blood moves easiest at the center of a vessel. So you can kind of picture even like red blood cells, right? They're kind of running into this vessel wall and getting slowed down. But then the blood right next to them, right, right? Those guys can slip by easier, and by the time you're out here in the center, this is your fastest moving blood. The blood at the center has the least resistance. Now, as we decrease the diameter, way more of the vessel basically becomes edge, right? You don't have that nice, wide open, kind of slipstream passing lane center of the blood vessel. And so here they're showing you cutting the diameter of a blood vessel in half. But here's the thing that happens. If you cut a blood vessel diameter in half, this is not a linear relationship, right? You could double the length, double the resistance. If you cut the diameter in half, you increase the resistance 16-fold, right? And that's an increase. The resistance 16-fold, right? It's in the physics of it. Don't get too worried about it, but realize that this is a much stronger actor on resistance. And it's what we change, right? Remember, particularly in our arterioles, that smooth muscle in the tunica media is able to adjust vessel diameter. Okay, that has major implications as far as resistance and therefore blood flow. Okay, so that's vascular resistance. The other thing we said was viscosity. Right? And viscosity, I always think about like motor oil, you can get different viscosities. Basically, higher viscosity is just more like sludge, right? So viscosity is a measure of the interactions of cells and molecules and things, and how they interact with each other kind of slow things down. So basically, if you have a more viscous blood, if you have thicker blood, if you have a higher hematocrit, that is going to give you more resistance. It's going to be harder to push it through the body, right? So increased viscosity is an increase in resistance, right, and a decrease in flow. What would increase viscosity would be an increase hematocrit. So something like dehydration, the classic doping, right? Take EPO, try to increase your red blood cells so you can carry more oxygen, but that is going to increase the viscosity of the blood. Maybe dehydration, a less nefarious way to get there, okay? The other one then is turbulence. And they have this nice picture here of turbulence, right, running into a plaque deposit. This is just like in the river, right? You get all these swirls and eddies. We want blood to have this nice, smooth, what we call laminar flow. Not this turbulent flow. So again, usually this is going to be some kind of damage to the endothelium, triggers this response where you might start getting plaque buildup, atherosclerosis, something like that. Some turbulence is totally normal, right? Anytime you like pass a valve or something, that's a disruption and you're going to get these eddies, right? And you got to overcome that resistance to keep the blood flowing, right? But again, big picture, right? Flow, don't need this picture yet. Flow is proportional to the change in pressure over resistance. If resistance increases, right? If vessel diameter is smaller, if the blood is really thick, if it's turbulent, lots of plaque, that all increases resistance. In order to get blood to still flow, you have to increase the pressure, which the only way to do that is to make the heart work harder. Mean arterial pressure is an important value that we can calculate, but before we do that, let's just think about what it means. So they're showing you here that this mean arterial pressure or average arterial pressure falls somewhere between the systolic pressure, so what we're feeling when the heart contracts, and that diastolic blood pressure during a period of ventricular relaxation. And so it falls out somewhere in between there, but it's not exactly in between. Now, mean arterial pressure is important because it tells us if our organs are getting perfused, right? We need a big enough change in overall pressure. We need a high enough pressure when we start out from the heart in order to make sure by the time we get to capillaries, we still have blood flow. So we actually need a mean arterial pressure of greater than or equal to 65. I think I did my caret the right way. Greater than or equal to 65 for mean arterial pressure. If values fall below that, we're at risk of not perfusing organs. That's something you would see in shock. So mean arterial pressure is calculated. Okay. So it's abbreviated MAP. And mean arterial pressure is going to be the diastolic blood pressure plus the pulse pressure divided by 3. Now, pulse pressure is just systolic minus diastolic. Right? So let's try this. This person's blood pressure is 120 over 80, right? Systolic, diastolic. And that's a pretty standard number that we would use. So how would we set up this equation? Well, diastolic blood pressure then is 80. And we want to add that to systolic minus diastolic, 120 minus 80 over 3. 120 minus 80 is 40. We'll divide that by 3 and add 80. 40 divided by 3 is somewhere in my notes. 13. Double check me on that. I'm getting 13. Plus 80 is 93. So that would be the mean arterial pressure. And that seems about right. We're a little closer. I guess a little closer on the diastolic end. So 93. We can try a couple more of these. You might even imagine, okay, what if someone had really low blood pressure, right? What would that blood pressure look like in order to be less than 65, right? Where we're in shock and we're not getting perfusion of our organs. So this is an important measurement that I guarantee you will see again in your healthcare related career. All right, and then to start moving towards wrapping things up, we want to think about the control of this cardiovascular system. So this is a trend, you'll see this over and over again in the systems that we're working through this semester, right? We always, that's misspelled, we always start out with autoregulation. Right? Trying to fix the problem in the organ or organ system that we're working with before turning to the nervous system and the endocrine system, right? Our big homeostatic systems. So in the case here of the cardiovascular system, autoregulation is going to mean how do we change if a tissue is not getting enough oxygen, right? How do we make adjustments in order to fix that? And we just want to do it at the site. So notice what they're trying to show you here, right? Somehow we're losing blood pressure, right? And they're pointing out this could be from some kind of physical stress, trauma, high temperature, something's going on here. Chemical changes, this would be like if you start working out or something, right? We're going to see changes, decreases in oxygen and pH, maybe increase in CO2 level as a result of that increased tissue activity. So if we're not getting enough blood flow because there's been some trauma or even just because we're working out, how can we restore that homeostasis, right? So realize here that what we're sensing are things like increases in CO2, decreases in oxygen, a decreased pH, which remember pH and CO2 are always inverse. We kind of use pH as a measurement of CO2 sometimes. Maybe increase in temperature. That's also an indication, right, to the body that maybe that tissue is working harder, has higher metabolic demands, right? So then we're sensing this kind of on site at the tissue, and what we need to do is figure out, in this case, how to dilate those blood vessels, how to increase the blood flow. And so we use a lot of like local vasodilators. Right, so this could be things like those same working tissues, right, might be releasing something like lactic acid. That's a vasodilator. Nitrous oxide is actually a really common one that's used here, right? And so if we open up those blood vessels, homeostasis gets restored. And of course this works the other way as well, so right, we can cause vasoconstriction. So at the site of injury or something, to very quickly stop blood flow, you release things like prostaglandins from those damaged endothelial cells or platelets, right, and we can cause constriction. So this homeostasis really can work either way. Okay, if we can't change blood flow the way we need to, right, if autoregulation is ineffective, we move towards the nervous system and towards the endocrine system. So when we think about how the nervous system interacts with the cardiovascular system, we're going to see that it's the medulla oblongata again that has the cardiovascular and vasomotor centers, right? So cardiac centers and vasomotor centers. So we're working with the medulla. Right? And again, this portion of the brain can change things with the rate or the strength of contraction as well as vasoconstriction, vasodilation. Now, the way the medulla is getting information about what is out of whack with homeostasis are through baroreceptors and chemoreceptors that are located in some of our vessels. So this input from baroreceptors, these baroreceptors are located in the carotid sinus and the aortic sinus. Right, so this sinus is just like a little pressure sensor that's embedded in the wall of either the carotid artery or the aorta, and it's going to tell the medulla how we're doing blood pressure. Is it adequate, too high, too low? You also have the chemoreceptors. And these are found in the carotid bodies and aortic bodies. And again, the chemicals we're looking for here, things like O2, pH, which again is the indicator of CO2. Okay, now this is annoying. The bodies aren't the baroreceptors, and if you ask me, that's some BS. It's the only way I can remember it, right? The baroreceptors are the sinuses, the chemoreceptors are the bodies. If you come up with a better way, let me know. Okay, so these receptors sending information to the medulla, and we're going to decide what kind of changes that we need to make here. Okay, so since we're dealing with the nervous system, again, sympathetic versus parasympathetic can give us very different results. Okay, if kind of the example I used down here, maybe we weren't having adequate blood flow to certain tissues, right? We would expect then the sympathetic nervous system to step in to tell us to do things like activate these centers make the heart beat harder, maybe the heart beat faster, and then to alter the level of vasoconstriction to get the blood flow where we need it to go. So again, sympathetic nervous system, we're expecting its result to increase cardiac output, increase stroke volume, increase heart rate, that sort of thing, and of course parasympathetic. Is going to be the opposite, right? Telling us to chill out and go ahead and decrease cardiac output. Sympathetic nervous system, as far as the vessels go, right, is going to lead to vasoconstriction. And parasympathetic, more vasodilation. And again, this vasoconstriction, we're using epi, norepi. Norepi is actually the bigger one there, as far as vasoconstriction goes. Okay, this again tends to be the quicker change, right? Endocrine changes are going to be the maybe a little more gradual but longer lasting. So if autoregulation fails, we move into both of these mechanisms. The nervous system is faster, so maybe it can fix things. But typically we're also turning to the endocrine system to try to make these adjustments as well. So again, if we think of it as, hey, this organ isn't getting enough oxygen, right? The endocrine system, we could think of maybe a hormone released from the kidney that would tell us to make more red blood cells and carry oxygen. If you said EPO, you're right? So things like the kidney producing EPO could increase red blood cells, increase oxygen delivery. You have the anterior pituitary, posterior pituitary, releasing antidiuretic hormone, tell us to hold on to water and actually increase our blood volume and therefore blood pressure, right? We can use that to help perfuse organs. And I'm going to introduce at this point, it'll be back, what's called RAS, the renin-angiotensin-aldosterone system. And we didn't really get into this in the endocrine system because there's so much other stuff there, but let's take a look. So again, this is renin-angiotensin aldosterone system. So the kidney, that's an arrow. The kidney is going to release renin. What renin does is you have a protein already circulating in your bloodstream. This was produced by the liver, and that protein is called angiotensinogen. Right? It is an inactive protein hanging out in the bloodstream, and when renin's released, it cuts the angiotensinogen into angiotensin 1. We're not done yet. I'm just writing across this whole board. We need that to be converted to angiotensin 2, and that is done by what's called angiotensin converting enzyme. Much easier to say ACE, angiotensin converting enzyme. Primarily in the lung, this conversion is taking place. Now, angiotensin 2 actually is going to do a few different things. So, well, let's go. Angiotensin 2 causes an increased release of aldosterone. right? So it's not converted to aldosterone, but if you recall aldosterone being produced in the adrenal glands, it's going to trigger the release of aldosterone. Aldosterone tells us to retain sodium, right? Which is going to work alongside of our antidiuretic hormone, right? If we retain sodium, water wants to follow it. So that helps us up blood pressure. Aldosterone is actually a vasoconstrictor, right? Makes us thirsty, all sorts of things going on there, right? But this is the renin-angiotensin-aldosterone system. Again, the kidney releases renin at times in response to low blood pressure. Sorry if I did not say that earlier, right? Low blood pressure, low blood volume, and so all these things are working to up blood volume or blood pressure. Okay. We do have mechanisms to go the other way. This is the really common side, right? Something like a low blood pressure, whether that's from dehydration, blood loss, etc. But there are times when actually blood pressure can get too high. We have endocrine response to that as well. That's where ANP and BNP, if you remember those from the endocrine system, come into play to tell us to dump water and decrease blood pressure.